Prova. So, my opinion is that here there is no case for endoscopy, so we need to choose the right case for endoscopy. Because if someone asks you to do an intervention, so time is running out, so we will not have two interventions. So the first question here is that if we can solve with weight regain. The second one is why do we keep malabsorption even if the patient is 63 years old and there is already an end of the gastric operation? Why is absorption scary? Absorption is scary when you do gastric restriction and malabsorption together, but here we only have malabsorption. So when you have malabsorption to this patient, we can see that this patient will lose weight very slowly, very slowly. So the response here is that malabsorptions can be distalized, and no, because distillation. So an option is doing a mini bypass, counting the answers from the SICOB. And this is the strategy. So you first of all restore the bypass. Not really. You do a bypass, a mini bypass, keeping into account this type of pouch of the bypass with a single anastomosis. So we want to also look at vitamins because in my experience, for example, the percentage of patients that eat a very high, very good quantity of proteins and that complies with the treatment, with the integrative treatment of supplementing, is very low. So the answer here is that we also need to look at this speech in a specific context. In a day, take. So here the discussion is not only malabsorption, for instance, like in the 2000s, when you would do this in a very pushed way. Here we are talking about patients that are highly selected, where almost always there has been the over endoscopic exclusion, and so we result on this malabsorption. So this is a principle that is super selected with a pre-intervention sharing. So here, endoscopy shows that anastomosis is very broad, and this leads the patient to eat a lot. And so, acting on the resize is is a principle, the length of the pouch and the diameter of the anastomosis. So, the endoscopic evaluation is always important. It's always the first step. Usually, these anastomosis are stuck. So, between the endoscopic options, I would like to remind that the BC done in a preliminary way, in an adequate way, is an option that today. So we have. We are now looking. Inside here is that this doctor has never seen in their experience a cul-de-sac that made the patient gain weight. We can see that the removal of the cul-de-sac did solve the reflux, but there has never been witnessing of this causing weight gain. In this patient, we have an anostomosized ends, which has a function that is similar to one of the stomach, but we cannot expect that with sectioning the cul-de-sac, especially if asymptomatic, the patient will lose weight. So we will now look at the third clinical case. So, female patient, 23 years old, 66 BMI, initial weight 170, 2018 sleeve gastrectomy, 2020 minimal weight 80 kilograms, 2023 weight loss of 90 kilograms, in weight regain with BMI of 35, appearance of hypertension and dyslipidemia. Today, this person is 27 years old. Studies also from a nutritional point of view of this patient. So here we can see the digestive tract, and here we can see the gastroscopy we start from Giovanni. So the endoscopic image here, the first thing to evaluate is whether the patient has had reflux problems, because the endoscopy is something that has to be imagined only if the patient at the state has not had signs of esophageal reflux. So what we can do here is a procedure that is still a little bit, there are no data in the literature that are calm enough. And so here the restriction with suturing, here we can imagine restriction again. So restricting again a sleeved stomach is something that we can do only if the patient does not present gastric reflux. Is that the patient should not have. Okay, so trying to get a tissue that does not come is very difficult. So the question here is that good. So the answer here is that, of course, we are looking at patients that get to endoscopy and that cannot do surgery or that don't want to do surgery. So here we have some sick people that have two conditions that are there, and so it's that either the gastric tubule is dilated, so we need to satisfy the first need, and the second one is there is no gastric esophageal reflux. This is a patient that is not eligible or does not want to be eligible surgically, and that can be evaluated endoscopically. Personally, I do not endorse a restriction on the long curve, or at least only on the long curve, because there we see worse results. So I often suggest an anastomosis and a gastric restriction that is circular. So we have two questions. So the first question is if you have the feeling, endoscopically speaking, that you perceive that the big curve is less mobile. And then, so the question here is whether you perceive that. And the answer is this: yes, I perceive that, because with the helix we go through, and so we see less feedback. So the feedback here. So the question is, how many sleeve revisions did you do up to today? And the answer is 41. So that is a lot. So here we are looking at a 23-year-old woman. She has a very good response. And the space for endoscopy here, honestly, looking at the radiography, we do not see much. We can see that the stomach is already very, very restricted. So technically speaking, it's a little bit hard to do this, at least in my experience as an endoscopist. The endoscope here is not able to put itself in a position that is appropriate. And so here we can see that it is also tight enough as a sleeve. So we now want to go progressively, so we can look at the end, and we can see that the endoscopy here cannot do anything because we don't have the technical space to do the font. So here the font is almost everywhere pre-represented. So we want to understand if this. So here we have a picture, and we want to understand if when we see this picture under scope, so endoscopically speaking, if this patient has a fund, so this patient is 23 years old, so the best idea is probably to do something that is more important than the endoscopic revision. We can also have its limits, as we know that there are a lot also of losses on the suture. So provided that systems of endostitch are good systems, but if the fund was very good, then the fundectomy would have a significance in a person like that, having they responded properly, but we don't really see the fund here. We don't see the fund here. We only have retroversion, and I do not believe that this patient has fund. Okay, so we can, if there is no fund, then for this patient we can change this in a gastric bypass LaRue. So we can also ask Dr. Dilleman. So I think that we should not forget. Allora, in questo caso abbiamo una persona con un BMI di 66 a livello iniziale e adesso siamo arrivati a 35. Non ho mai visto una sleeve così di successo dopo 5 anni, passare dal 66, a prescindere da quali sono stati i vari pesi, è importante capire che è stato fatto un buon lavoro, che ci sono alcuni cambiamenti, ma da 66 di BMI a 35 di BMI è qualcosa che non è per nulla di non successo, è qualcosa di fantastico e quindi devi stare lontano da qualsiasi procedura chirurgica. Io penso che sia fantastico. Questa persona ha comunque 23 anni, però metabolicamente parlando era in salute, adesso è ipertesa, però questo in un BMI di 35, se guardi a tutti i criteri devi guardare al peso, alla perdita di peso totale, che perché sono parametri più importanti dell'effettivo peso. È stata una persona eccezionale, era eccezionale ok, quindi la domanda è se sarebbe una buona idea fare una ROMY su questo paziente. La risposta del dottor Dilleman è che questa persona prenderebbe peso così facendo. Ma c'è un disaccordo. In un caso simile, molto simile, che io ho fatto qualche mese fa, io ho deciso di fare una re-sleeve perché non pensavo di passare altre chirurgie e in questa chirurgia c'è la possibilità che ci sia comunque anche la fortuna come opzione. So to be practical, who would do a mini bypass on this patient?
Di non lasciare l'aula, c'è l'assemblea, perché c'è l'assemblea dei soci che è un momento importantissimo per tutti. Telegrafici, qualcuno farebbe un mini bypass?
Okay, so would anyone do a mini bypass on this patient? The answer is one person. Would anyone do a SADIS on this patient? No, the person is too young. The main idea is that she is too young for the SADIS. Okay, there is an intervention. So according to Dr. Dilleman, a SADI will be the best option. And the question here is even if she wants kids. Allora, se vuoi lavorare per ipoassorbimento ci deve essere comunque disciplina, ci deve essere rigore, ma poi di nuovo questi risultati sono comunque ottimi, è una fantastica sleeve. Okay, we are not doing final remarks. So the option of Giovanni is that we either do nothing or if we do something, we try to remember the story of the sleeve gastrectomy. So sleeve gastrectomy is a surgery that was invented for super obese patients where sleeve was the first part of the malabsorption intervention. So if we have to do anything, we don't have to give the last opportunity, but at least an important possibility of not losing the situation, so at least a little bit of malabsorption. So the objection here is that 28 is fertile age. So if you have no other questions, so the session is closed. We want to thank Dr. Dilleman for his presence and his great contribution. And so see you all in Naples. Ci vediamo a Napoli. Grazie a tutti, arrivederci, grazie a tutti.